So we'll finish off urogynecology now. Okay. So we in the beginning, that is in the basics class, we know that the supports of the uterus we studied. Okay. The supports are going to be, the major supports are, one is going to be cardinal ligament. This otherwise called as Meckenroths. That is in the sides. Okay. And then second is going to be pubocervical. Pubocervical is from the cervix to the pubic symphysis. That will be in the front. Okay, if suppose this is going to be the cervix and the uterus, the sides it's going to be cardinal ligament. Okay, in the front it is going to be pubocervical because this is the pubis, and here it is going to be the sacrum. Okay, and the third is going to be uterosacral, that is from the uterus to the sacrum. Understand? So these are the major ligaments. Then apart from that, what are the other ligaments that we know of? Round ligament, then broad ligament, yes, and then two ligaments which are supporting the ovaries, that is ovarian ligament and infundibulopelvic ligament. Okay, but these are all not important for uterine support. Only the major supports are cardinal ligament, uterosacral, and then and the pubocervical ligament. Now coming on to the D. Lancey's classification. D. Lancey's we saw na level 1, 2 and 3. Level 1 is going to be uterosacral and cardinal ligament. Level 2 is going to be in the middle, that is pelvic, lateral attachment to the pelvic side walls, that is fascia pelvis. Okay, pelvic fascia. And then third is going to be the levator ani and perineal body. Okay, you remember in the morning we saw all these. Okay, so now if the supports are gone, what are the defects that can be created? Okay, the defects is going to be, if the first support is gone, then what happens? UV prolapse will happen. Okay, UV prolapse will happen and there will be enterocele. Okay, whereas in so wait, we will see here. Okay, so in level 2, if it is gone, it will create anterior and posterior wall defect. Okay, if the that is if the middle support is gone, that is facial support is gone, then that means anterior and posterior wall defect will happen, and it will also give rise to stress urinary incontinence. Okay, if level 3 is gone, it will result in lax perineum. Okay, now level 1, it is going to be UV prolapse and enterocele or vault prolapse. Now, if you see in the uteroprolapse, in the uterovaginal prolapse system, that is UV prolapse system, anterior and posterior. Okay, anterior, what are the structures that are present? Bladder and urethra. Is it not? And at the same time, posterior, it is going to be rectum. Sorry, intestine. That is enterocele and rectum. Correct? Understood? So, anterior prolapse, anterior wall prolapse and posterior wall prolapse means the upper anterior wall prolapse is bladder, lower anterior wall prolapse is urethra. Upper anterior wall posterior wall prolapse is enterocele and lower posterior wall prolapse is rectum. So, in between the uterus will be standing like this. Understood? Yes. So, this is what is actually given here as anterior and posterior wall prolapse. You understand? Okay. And the third level of support, if it is gone, it will create lax perineum. Okay, because it is lower down. Okay. Now, what is the terminology? Terminology. What is going to be cystocele? As cystocele, we said it is anterior upper, urethrocoele anterior lower, enterocele is posterior upper. Very good. Rectocele is posterior lower. And then last is going to be deficient perineum. Deficient perineum means from between the vagina, that is introitus, and the anal verge, the space is very less. Okay. Now, what are going to be the degrees of prolapse? First degree is going to be into the vagina. Second degree is at the level of introitus. Third is going to be outside the introitus. Fourth is complete procedentia. Okay. Yes. So, this is called as POPQ classification. POPQ classification is a classification which can stage the prolapse. So, according to that, we are staging the prolapse into 4 stages. This is all very high, not needed. It is PG level. Okay. So, what are the investigations that you can do? It is mostly prolapse is mostly by clinical examination only and clinical evaluation only. It can be determined. But other than that, if there is going to be any urological complaint, you can go for urodynamic evaluation. Otherwise, rectum, if there is any problem, proctography. And then if you suspect any other lesion, then MRI can be done. Understood? So what is this? uterine prolapse with an ulcer here. That is called as decubitus ulcer. So decubital ulcer, what do you do? First, you do a cytology test and see to that ulcer is normal. And then what happens? You have to reduce the prolapse and apply estrogen cream continuously so that the decubitus ulcer will get cured. Understood? So what is the conservative management and surgical management? There is no medical management for prolapse. Everywhere we would have studied medical management, minimal invasive surgery, and then surgery. Correct? But here there is no minimal invasive surgery or there is no medical management at all. Either you conservatively manage, how do you do? You actually weight reduction, lifestyle modification, pelvic exercises, and vaginal pessary. The next is going to be surgical procedure only. Surgical procedure, what is the concept is you have to correct the part which is defective. You understand? It is most of the times people understand that for prolapse it is hysterectomy. No, hysterectomy is not the treatment. Why prolapse has happened? Because of the defect in the support. Okay, only because of that the uterus has come out. If you just remove the uterus, the support is not going to be corrected. Understood? So the correction has to be done according to the problem, the site of problem. Okay. So if it is an anterior wall prolapse, then that is anterior wall prolapse, anterior colporrhaphy has to be done. That is pubovesicocervical fascia. Understood? And posterior wall prolapse, you have to go for facial because see, why fascia? Fascia is it coming? The second deal and see, anterior and posterior wall. What is the problem? Fascia is the problem. So facial support has to be done. You understand? Okay. And that is, and then in case of lax perineum, you have to go for perineorrhaphy. Okay, stage 3, you have to go for perineorrhaphy. And then what is another procedure called McCall's scaldoplasty? McCall's scaldoplasty means it is done for enterocele. Okay, so here the plication of the uterosacals is done, attaching the uterosacals to the vaginal vault. Okay, it is done for enterocele correction. Okay. So here, what are the surgeries that you know of? Surgery can be uterus preserving surgeries and surgeries which are done along with hysterectomy. Okay, understood? So here, what is the uterus preserving surgeries that you know of? That is, it's called Fothergill's or Manchester surgery. And then it is going to be sling procedures. Why do you want to conserve the uterus in case of nulliparous prolapse? In nulliparous prolapse, that is the patient has not yet conceived, you need to save the uterus. Okay, in those conditions, you either go for Fothergill's or you go for sling procedure. Understood? And in rest other cases, what you do is you always combine vaginal hysterectomy. That is, you combine vaginal hysterectomy along with site-specific repair. Understood? Okay. So there are various see vaginal hysterectomy along with anterior colporrhaphy, otherwise posterior colporrhaphy, McCall's scandoplasty. You understand? Okay. What are the surgeries for vaginal vault prolapse? Vaginal vault prolapse means you have done the vaginal hysterectomy, okay, and you have sent the patient without even correcting the site-specific repair. What will happen? The vault will also prolapse because there's no support. You understand? So, how will you correct this vaginal vault? Means vaginal vault is once again you have to go for doing colpopexy. Colpopexy means vault is suspended. Understood? Colpopexy means vault is suspended. It can be either abdominal, it can be vaginal, or it can be laparoscopic. Understood? Okay. So all these pexies, that is suspension, is done by using mesh. Understood? Okay. 26-year-old nulli gravida. What do you do? Hmm? Nulli gravida means uterus has to be conserved. Only two things is done in uterus conserving surgery. One is Fothergill's and second one is sling. Okay. Right? So here the answer is sling. Why? Because here Fothergills is a surgery where you do amputation of cervix. Amputation of the cervix means you cut the cervix and then stitch the uterosacrals to the front. Okay. In Nulli gravida, if the cervix is longer, you will be able to cut. So infravaginal elongation of cervix should be there for Fothergills. You understand? So whenever nulliparous prolapse comes, only two things has to come in your mind. One is Fothergills, second one is sling operations. Sling is very simple, just to lift and attach. Okay, but in Fothergills you amputate, so you need a longer cervix, which means infravaginal elongation should be there. Understood? Here nothing is mentioned about infravaginal elongation, so the answer is abdominal sling. Okay. Treatment of decubitus ulcer. Is infection the cause for decubitus ulcer? Packing. Yes. Just reduce the prolapse and maybe estrogen cream. McCall's cultoplasty is done for Enterosil. Very good. True about pessary. True. See, pessary is a pessary is a conservative management. Okay, when and all you do a conservative management is first thing when the patient is very old, she cannot be posted for surgery. Okay. Second thing is the patient needs time for her to prepare for surgery. Okay, needs time. Or third is if the patient is pregnant. Okay. Or the fourth is going to be sometimes the patient might have a decubitus ulcer which needs to heal. So until then, you need to do something for the prolapse to be reduced. So these are the conditions where you use pessary. Now, what is true about pessary? What is the answer for this question? Very good. The only thing that is actually correct is going to be needs to be changed every 3 months. Okay. Pregnancy also it can happen. I have a case right now with uterine collapse and pregnancy. Uterus will not come down. Uterus will be there only with the fetus inside. But it will come, that is, it will not come out of the vagina. It will be inside only. You will be able to see the cervix outside. Ah. Oh, you confused with uterine inversion. Okay. Conservative management of pelvic organ prolapse. Pessary. Yes. Okay, good. Now moving on to the urological part. Okay, urinary tract. Right? So here, bladder. Okay, so bladder. Okay, so here what happens is bladder is there. So the bladder has got detrusor muscle. Okay, and then there is a vagina. There is a urethra. Okay, urethra has got two sphincters: internal sphincter and external sphincter. Understood? Okay. The intrinsic sphincter is continuous with that of detrusor. So detrusor is a continuation of the intrinsic, but whereas extrinsic is a external muscle that is provided by levator ani, that is pubo-urethralis. Understood? Innervation. Understood? Understood the musculature part. Now coming on to the neural part. So what happens to the neural part is you understand only two things, that is parasympathetic and sympathetic. Okay. If you understand, if you grossly, that is if you generally remember, sympathetic means sympathetic innervation. What does it do is I always say it like this, that is, if suppose you are running away from a danger, okay, you will tend to run very fast and you will escape. Okay, in that time, will you take time to go and pee? No. So that means the bladder should fill, urethra should close. You understand? So sympathetic fright, flight, and fight mode. In that time, bladder will be relaxed. That is, bladder will be detrusor. That is, detrusor will relax and intrinsic sphincter will close. You get it? What I'm saying? So bladder will fill and urethra will close. Only if the danger is gone, you will feel relieved. So sympathetic activity will come down. Parasympathetic activity will be there. So in that parasympathetic activity, bladder will contract. That means you will be able to urinate. You understand? Okay. Understood? And will urethral sphincter will relax. Understand these two? Apart from that, there is another. Apart from that, there is another innervation by the pudendal nerve, that is motor fibers. Okay, that is the motor fibers which is through the pudendal nerve. It is supplying the levator ani and sphincter urethrae. So they have a contraction once again. So motor fibers voluntary control. Okay, yes. So these are the innervations. Now what happens is as the bladder fills, bladder will relax and urethra will contract. Okay, 150 to 200 ml, the first urge will come. Okay, maximum is going to be 400. Okay, levator ani muscles, as I said, it's going to have a voluntary contraction. It is also going to hold. Okay, whenever you feel like you want to release, or whenever you feel that it is appropriate time to urinate, the inhibition will be released at the appropriate time. Understood? So then at that time what happens? The detusa will contract and urethral sphincter will relax and it will let the urine out. Understood? Yes. So what are the different types of incontinence? So whenever there is a problem with this holding and relaxing, it results in incontinence. Okay. So there are different types of incontinence: stress, urgent and urge incontinence, mixed incontinence, overflow incontinence, and others. Stress incontinence is purely because of urethral hypermobility or intrinsic sphincter defect. That means the sphincter defect is gone. So whenever that is you laugh, or when you sneeze, or when you cough, suddenly that sphincter will open. Okay, so it will let your urine out. Okay, that is stress incontinence. Urge incontinence is whenever you feel the bladder is full, immediately the bladder will let the urine out. Okay, you will not be able to get the time to go to the restroom at all. Understood? Combination of these two is mixed incontinence, and then overflow incontinence is detrusor overactivity or bladder outlet obstruction. Overflow incontinence. Okay, and then functional incontinence and all, it is psychological. Okay. So SUI, I just explained you. Whenever there is an increase in pressure, it will let the urine out. Okay. So what do you do in what is the test that you actually do in this urinary incontinence is first and foremost thing, rule out infection. So UTI has to be ruled out. So do a culture. Understood? And then there is and then it is Q-tip test. Q-tip test is to understand the urethral hypermobility. Okay, that is you have to insert a Q-tip. Q-tip means the buds. Okay, insert into the uterus, that is sorry, urethra. And what you have to do is you have to measure the normal angle from the plane. Okay, and when you ask the patient to cough, this Q-tip will move. Understand? So what happens? The angle. If the angle is more, that means the mobility is more. That is urethral hypermobility. So that means it is a stress incontinence. You understand? That is Q-tip test. So Q-tip test is done in SUI. And then the other things are monitoring, like having a voiding diary, no understanding how the urination is and everything. Okay. And the next is going to be urodynamic studies or urodynamic evaluation. This is done only in cases where you will not be, that is you are not sure about the diagnosis of what is exactly the problem. Okay. When it is uncertain or any other neurological dysfunction is suspected. Understand? So these are the different urodynamic evaluation tests: cystometry, uroflowmetry, cystometrography. Okay, all these. Now, what are the treatment modalities? As usual, it is conservative one step. That is, you ask them to do exercises, lifestyle modification, all that. Okay, and then it is going to be medical management and surgical management. Understood? Yeah. Okay, so medical management and surgical management. So here what happens is usually SUI is a condition where it is always managed surgically, because what is the cause? It is two things. One is hypermobility and second thing is intrinsic sphincter defect. Okay, so what you have to do is you have to tighten it, tighten the area which is loose. You understand? So we put what is it? That is, we put lots of suspensions. You just hold and lift it up. Okay, suspend the urethra to various places. Like it is going to be suspended to pubic symphysis, or it can be suspended to Cooper's ligament, or it can be suspended to white line of pelvis. Understood? Yes. Colpo suspension. Okay. So Birch colpo suspension or laparoscopic colpo suspension or MMK procedure, all these are nothing but suspending the urethra to a fixed point. Understand? Next comes urge incontinence. What is urge incontinence? He feels like urinating, the urge, he will urinate. Understand? Okay. Here, urge incontinence can be easily attended medically. What are the medical management that you know of is anticholinergics like solifenacin, oxybutynin, and nowadays the recent drug that has come is mirabegron, which is a beta 3 adrenergic agonist. Understand? Now answer. Yes, very good. Central incontinence. Yes. Okay. Now coming on to the fistula and injury to the urinary tract. Okay. So here, what are the different types of fistulas? You see, vesicovaginal. Okay. Between this is vesicovaginal. Okay, between the bladder and the vagina. And second is going to be vesico-urethrovaginal, that is in the junction part. Okay, third is urethrovaginal. Okay, fourth is going to be vesico-cervical. Understood? Fifth is going to be uretrovaginal, that is ureter and vagina. Sixth is going to be vesico-uterine. Understood? So these are the different types of fistulas that you know of. Okay, from each and every part. Okay, yes. So what is the etiology? Most common is going to be some injury that has happened either during obstetric procedure or during gynec procedure. Okay. So at any point you will have a you would have had a injury. Okay. So in bladder fistula, what happens is continuous dribbling of the urine will be there. Correct, because bladder, from the bladder it will enter into the vagina and it will keep dripping. But whereas ureteric fistula, once again, ureteric fistula will also have a continuous dribbling, but she will also be able to mixturate normally because the other side will be normal. Correct? The other side urine will be coming into the bladder. You understand? Yes. Whereas in urethral fistulas, there will be no dribbling, much of a dribbling. Why? Because only if the urine comes into the urethra only there will be dribbling. You understand? Good. So this is a test which is called as 3 swab test by using methylene blue. You keep 3 swabs, okay, and then you inject methylene blue dye and then watch what to do. Okay, if the second is filling, that is, if the second is wet, it means bladder fistula is there. On urinating, if the third is getting wet, it is urethral fistula. If it is not at all wet with any methylene blue, it means ureter is attached. It will be wet with what? Urine. Understood? Yes. So, uretrovaginal, vesicovaginal, urethrovaginal. 3 parts. Okay. Now, what are the procedures? I mean, what is that can be done? Can it be treated medically? No. Only surgery is done for all this. So, somehow you have to close. Okay. So, you put a graft. So, you put a graft and you close. Okay. Somehow you have to close by using a graft. Understand? Now, listen to that. History of difficult labor and cesarean section presents with watery vaginal discharge on 7th postoperative day. What what do you suspect? Okay. Yes. What is that watery vaginal discharge? Urine. Okay. Middle swab is stained with dye. Imagine the picture. So, huh? Yes. Okay. Uretrovesicular, vesico-vaginal. Where are you keeping the swab? Vagina only, la. Correct? First swab is from what? Ureter. Okay. Second swab is bladder. Third swab is urethral. Yes. Understood? Okay. So we are done with urogynec also. And we have 1% charge left.